and a computational biologist who has pioneered precision medicine and clinical genomics in India. So today he is going to talk on personal genomics are moving the needle for precision medicine. So please join with me to welcome Dr. Vinod.
Thanks for inviting me here. It's a pleasure to be back here in Vellore. Over the next 20 odd minutes, I think I'll discuss a bit on personal genomes and how personal genomes are moving the needle for precision medicine. And before I start my talk, I think I'll go back a bit into history. And I'm sure many of you would recognize what this instrument is. This is only 50 years old. And for the first time in the history of 50,000 years of modern humankind, clinicians were able to peek into the human body without having to open this up. And I'm sure you would appreciate that many people in this audience, clinicians especially, would use this left, right, and center, and many of us would have gone through this instrument very often. Now, I brought this out because for the first time when you can peek into the human body, just 20 years ago, we can just also not peek into the human body, but actually peek into the blueprint of every one of our 30 trillion odd cells, and that's our ability to sequence the human genome. Now, the real question is, what can we really use this genome sequencing for? And obviously, that is also because of the fact that we do genetic tests. And the previous speaker did allude to many of these genetic tests. And in fact, in a clinical setting, we do many more of these genetic tests. Right from chromosomal karyotyping, you can do FISH, you can do chromosomal microarrays, you can do mitochondrial sequencing, all the way to, in fact, many of the patients actually go through multiple of these. Each of them are complicated by its own ways, its own means, and it also costs quite some money to do any one of these tests. Now, what I'm trying to say is that a whole genome today encompasses every one of these single tests into one single test, making it faster, cheaper, and of course, more affordable going forward. Now, how do we really use this in clinical applications? And one of the major areas you would use this in clinical applications is to be using it for the diagnosis of rare genetic diseases. And to put numbers, a typical patient with a rare genetic disease, if fortunate, would go through a diagnostic odyssey of 5 to 7 years. 30% of them would die even without a diagnosis. Now, how can we really change this? Because these are problems worth solving. Just let's take a case of metabolic disorders. They come in multiple different sizes and forms, very difficult to diagnose in a clinical setting. They come with very high mortality, very high morbidity, and a very small window for treatment. And if you have lost the treatment opportunity, you essentially have a child with a permanent neurological deficit. Now, that necessarily means that you need to be able to diagnose, very fast. And of course, whole genome sequencing, just because of that ability to offer a broader test, to offer it faster, has already now come into the guidelines of many disorders. Just a subset of these, developmental delay, intellectual disability, chromosomal abnormalities, and of course, unexplained epilepsy already are in the major guidelines. And it can reduce the diagnostic odyssey of patients to a considerable number. This is just 2 weeks ago, a large cohort from Seattle Children's who were doing a standard of testing before May 2022, adopted to a rapid genome and exome, and you can just see what really happened. From an average time to diagnosis of around 289 days, it has reduced to just 13 days. And I think our kids do and should benefit from it. And in fact, this is not just in US, it is today possible in India. We can routinely do rapid genomes, or in fact, ultra-rapid genomes, and be able to provide a diagnosis at around 48 hours. Now, the real question is, of course, you can do this for newborns. Can you do this for pre-symptomatic children? And of course, there's a methodology to do that. It's called a newborn screening. So the best newborn screening programs in the world, in the US, does for around 37 odd conditions, a very small subset of conditions which today are treatable, and with a diagnostic yield of approximately 1 in 300 to 1 in 500 newborns. Now, of course, different states do have different of these gene list in the newborn screening program, but the recommendation is to do approximately 37 odd conditions. Now, to be frank, there are around 800 odd genetic conditions which are treatable anywhere in the world. Now, it is going to take ages before you can upgrade this from 37 to 800 odd. The only other way is to probably do a whole genome sequencing, and people have started doing that. This is early data from the Guardian study, which did around 4,000 odd newborns. And what they show is that you could put a 10x increase in the screen positivity rate from around 1 in 300 to approximately 3.7%. Now, just think of it. These are apparently normal newborns born into the system. You could do a whole genome to be able to identify a genetic condition is approximately 3.7 odd %. Now, of course, you can do this on a genome scale, but then, of course, in a country like India, the question is, are 800 odd genetic disorders treatable? Apparently, the answer is not. We put together a number of clinicians, many of whom are in the audience, who contributed to this initiative to put together a list which is applicable to India. And today we have around 453 genes linked to around 469 disorders which are treatable in India and therefore can be reported on a whole genome sequence. Now, of course, it's just about children. What about mothers? And if you can, for example, sequence mothers, what would you get? One in approximately 43 odd mothers do have a genetic condition which can affect their pregnancy or can affect the children. And that is a significantly large number. Can we really put this into clinical practice? Now, what about apparently normal people? Apparently normal people like you and me who don't have a well-set clinical condition, what if you could screen? And this is data 2 weeks ago from G-Sync Health. 288,000 individuals screened using an exome, not a genome sequence. What they show is that from the 3% apparent diagnostic yield, which is typically consistent across multiple different studies, you could now improve it to approximately 6.5%, almost double the diagnostic yield. And the obvious question is that does this diagnostic yield in genetic variants really contribute to the outcomes? They went back to the EHRs, and what they show is that approximately 15 to 20% of individuals do have an EHR record consistent with the diagnosis. Many more are probably on the way to be deceased individuals. In other words, you can actually increase the diagnostic yield by just being able to sequence even apparently normal people. Now, of course, the question is, can we do this in India? And of course, this is early data from the Indigen program. What we show is that approximately 5% or 1 in around 20 individuals do have medically actionable finding. And just count the number of people in here. 1 in 20, you have a medically actionable finding. If you don't know, probably a genome can resolve that. We have numbers that approximately 2% of them have a hereditary cancer. Approximately another 2% of them would have a cardiovascular disease, including familial hypercholesterolemia, cardiac channelopathies, and cardiomyopathy, all of which have guidelines for treatment and prevention. Now, the obvious question is, how can we really scale this up? And for example, if I look at BRCA1, BRCA2, which comes with a lifetime risk of approximately 60 to 80% of developing a cancer, breast and ovarian cancer in women, and prostate and pancreatic cancer in males. And the Indigen cohort, approximately 1 in 140 odd individuals do have a BRCA1, BRCA2 pathogenic gene variant. Now, that's a significantly large number. You can just multiply it by 1.4 billion people, and you will understand how many more million people are at risk of developing cancer, whether you're male or whether you're female. Now, assume that you can diagnose these conditions. The question is, can we treat them much better? The answer is probably no, because the state of the art essentially suggests that we today have drugs which don't affect or which don't act upon every individual in the same way, and that's largely because of the fact that individuals are different in their pharmacogenomics. Now, if you really look at the pharmacogenomic profile of Indian population, what we show is that approximately every individual that you could sequence would have 8 clinically actionable pharmacogenomic variants based on today's guidelines. And these guidelines are improving over the time. And for example, if you look at very specific variants like CYP2C19, STAR2, which essentially means that you're resistant to clopidogrel, that's approximately around 10 or 13% of Indians. So 13% of Indians are actually getting clopidogrel after a stenting procedure. Cardiologists out there would vouch for this. They would have a stent reocclusion coming forward probably weeks or months later, just because they have a STAR2 homozygous variant for CYP2C19, which makes it clopidogrel resistant. Now, there are many more drugs that we all take, including many in the audience, for example, statins. What we show is that probably almost 1/3 of individuals would require a dosage modification for at least one statin, and 1/10 of individuals would require a dosage modification for most statins. In fact, you require a much lesser dose of statins going forward, and you can avoid statin-associated myopathy by doing this. Now, that also would mean that we have a fantastic new opportunity to be able to change the way we practice medicine and the way we practice genomics. Today, we practice genomics or medicine with a basic concept that patients will come to you. Because you're a hospital, because you're a clinician, you're trained to look at patients, and therefore patients will come to you. Now, just keep in your mind that a patient comes to you only when you have a disease, right? A normal person walking on the road does not step into CMC Vellore and comes and contacts a clinician and says, let me know what is wrong with me. That's never going to happen, right? Now, if a patient comes to you, it's not that straightforward. There's a long diagnostic ODC. Of course, you will elicit signs, symptoms, you will offer labs, you will get a provisional diagnosis, and today what genetics is used at the end of the diagnostic ODC to be able to confirm the molecular diagnosis, right? And today it's too late, right? 289 days, in the number that I mentioned before, is an average that you take for even the serious odd cases. Now assume that you can reverse this altogether, right? Assume that you can all get your whole genomes done today, right? And if you have a pathogenic genetic variant, you can today step into a clinician's office and tell that I do have a pathogenic genetic variant. Now, how do I go about doing this? In fact, there are guidelines now available for a large number of conditions, including the conditions my previous speaker has sort of mentioned about. You can, for example, have a red carrier individual, quite very prevalent, approximately 1 in 1,000 individuals in the population. You can step into a clinician's office, and the clinician will guide you what to go about doing. Now, that would necessarily mean that you can put genomes in the first place and prevent the onset of the disease, at least in a significant number of cases. And that would necessarily mean that we would be able to change the way we practice medicine, because practically all of medicine that we practice is at that point where an individual develops signs and symptoms. For an individual who don't have signs and symptoms, have practically nothing to do with modern healthcare. And what clinicians do today is to be able to diagnose, prognosticate, treat, and monitor. There is pretty much nothing in modern textbooks about how to move this even to the left to be able to assess germline risk through screening procedures and be able to prevent the disease from its onset. And of course, across the world, things are changing. And of course, I'm not sure if you have followed the news. The NHS plans to sequence genomes of every newborn going forward in the next 1 decade. And this necessarily would mean that thousands of individuals would get diagnosed at birth, and clinicians will be able to treat them even before the disease strikes. And that's possible because today a whole genome sequence is constant from the day you're born to the day you're dead. But there are multiple different questions that you can ask all throughout your lifetime. Like, for example, in a newborn period, you would want to look at treatable intellectual disabilities. You would want to look at hemoglobinopathies. You would want to look at very prevalent genetic disorders which are treatable, like, for example, Wilson's disease, cystic fibrosis, primary immunodeficiency disorders. These are not covered by standard newborn screening programs. Now, of course, late onset in childhood, you would want to look at, for example, deafness, cardiac genetic abnormalities, neuromuscular disorders, so on and so forth. In mid-adulthood, you want to look at neurodegenerative disorders, and more importantly, you would want to look at carrier screening. Like the previous speakers talked about carrier screening for sickle cell anemia, carrier screening for thalassemia. Today, you can do it for the universe of genetic diseases available with just one single test. And of course, as you grow older, you want to access carrier screening risk for cancer, for example. You would want to look at pharmacogenomics as you start taking drugs. And of course, in old age, you would want to look at malignancies, Parkinson's, and Alzheimer's, which are also increasingly becoming treatable currently. I think the number of things that you can today report from a whole genome sequencing is, this is a very small list. It's counting and growing very rapidly. And therefore, I think it's really, really valid to be doing a whole genome sequencing. And just to put a Chinese medical text out here, superior doctors prevent the disease, mediocre doctors treat the disease before it's evident, inferior doctors treat the full-blown disease. What are the type of clinicians that we want to be? Are we going to be those superior doctors, or are we going to be forced by patients with the genome to be superior doctors? I'll stop there. Thank you very much.
Thank you. My question is regarding when doing a whole exome or whole genome sequencing, what happens, how do we address the variants of uncertain significance? Wouldn't we be getting a large variant of uncertain significance which has to be addressed? Second question is what happens to the depth of sequencing as we are screening more genes? Would it be affected, or the depth of sequencing when we do a focused NGS versus a whole genome sequencing, is the depth of sequencing affected? Will it affect the quality of reports? Thank you.
Thank you for that question. I'll answer the second question first. Now, depth of sequencing has nothing to do with the diagnostic accuracy, right? Now, to be very specific, we do a 100x sequencing on a whole exome sequencing typically, because of the fact that not all regions are covered equally. So, to account for the poorly covered regions, you sequence regions much larger, right? Now, if you do a whole genome sequence, you don't have a PCR step which accounts for the differences. You don't have a capture step which accounts for these differences. So, you can actually do much better accuracies at much lower coverage. Okay? Now, answering your first question, yes, of course, when you do a broader test, you will get very large number of variants of uncertain significance. But then variants of uncertain significance are not to be clinically actioned upon. And in fact, a vast majority of variants of uncertain significance are actually benign variants, right? The reclassification probability of a VUS over a decade period of time is only less than around 5%. So in all practical purposes, VUSs has no value in clinical actionability. So you should not really be worried about it, whether you do an exome sequence or whether you do a whole genome sequence.
A good number of cancers may not be not only about cancer. There are several conditions where mosaic is quite important.
Yeah, absolutely. So even the mosaics have absolutely nothing to do with the depth of sequencing per se. It has more to do with the quality of sequencing and the uniformity of coverage. Just to put an example, if you want to have a 10% variant allele fraction, that means a 10% mosaic cell, you can today get in a 30x whole genome, right? You will have 3 reads. But if you were doing, for example, somatic sequencing, for example, a whole exome sequencing, you might actually need 300x for the same accuracy for a 10% variant allele fraction. So it has practically nothing to do with the coverage per se. It has more to do with the assay and the sequencing accuracy in the first place.
Vinod here. I'm impressed with the idea that we should start doing a lot of genome sequencing. But the question is, what are the major challenges you have faced or you see in the Indian context?
Convincing clinicians.
And what is the cost of whole genome sequencing in
Not
India?
very different from a whole exome sequence.
Mm-hmm.
So I'm a clinician, so I have a question. So if we start doing it and moving the needle to the left, what would be, will you be changing all neurotic to psychotic people? Or do we need more therapists?
Yeah, so the unfortunate answer to that is, yes, we will be treating a lot of pre-symptomatic, asymptomatic individuals for sure, right? And for that matter, we already do that, right? In fact, if you look at a newborn screening, right? A newborn with a screen positive, confirmed with a diagnosis, we already treat them, right? So what is really different, right? Something that we already do, we are probably doing at a much larger scale.
Sir, so in your whole genome sequencing, what is about your somatic problems? Like, because somatic over the years, they are going to develop the disease.
Yes, yeah, completely agree that there are some somatic events which are important. You would need a bit larger coverage to be able to identify the somatic events or be able to access the right tissue. For example, one of the somatic events which are traditionally missed out in germline testing on blood is, for example, segmental neurofibromatosis. Right? You will not get in the blood because blood is a mesenchymal origin. You need to be a bit intelligent to be able to go back and see that I will take a tissue from the segment and be able to sequence, you will get it. So it's not the problem of the test in the first place, but the problem of understanding what is the best tissue to look at for answering the question that you want to look for.
Dr. Vinod, one question is there in the online. How is the ethical concern is giving away the genomes of population to companies is addressed? Can there be chances of being misused? How do you see many corporate companies jumping inside the market of personal genomics?
Yeah, to be very, very frank, right, there is much more information that I can act upon that's already available on your email, that's already available on your Facebook, Instagram accounts, right, that I can today act upon and actually sell something to you, right? I've still not got a use case where I can use a genome to sell something to you yet. So there goes my answer.
What so far really has been the outcome, for example, for newborn screening, where you have potentially new information in terms of potentially new disorders or something? What has the path been, what has the actionable path been across the world? And how are people, if it's a new disease, what is the model for it?
Yeah, absolutely right question. So, see, the basic concept of a newborn screening is that you can identify prevalent, highly penetrant, treatable genetic disorders which have an affordable, accessible therapy. Right? This is part of a large constellation of rules, what we call as a Genomes criteria. Globally, newborn screening follows the Genomes criteria. Now, the broad question is, even the best countries in the world limits its newborn screening to 37 odd conditions. Because these newborn screenings were initiated 30 years ago, the 37 odd conditions were relevant 30 years ago, but now the treatability of conditions have expanded enormously. Just to give an example, Risdiplam, which was a 6 lakh rupees drug until yesterday, right, the court order have put it at 15,900. Now, every SMA kid could afford to have Risdiplam, right? Now, the question is, where are these SMA kids, right? Do our newborn screening programs do screen for SMA? Answer is no. So, we are going to identify an SMA kid when the kid is over the edge, right? Beyond treatability. There's no point. Many diseases in India which are treatable and very prevalent are never covered under newborn screening programs. Best example is Wilson's disease. I'm sure every single medical student in here would have seen a Wilson's patient. Wilson's is treatable with a 3,000 rupees drug, generic, manufactured in India, but we don't have a newborn screening program because we follow a newborn screening gene list which was created elsewhere in the world, right? Now, how are you going to negotiate this? Are we going to keep arguing that this should be there or that should be there? Or should we do one single test and decide then what should be reported? My obvious answer to that is, let us do it first and then report, right? If I had an SMA kid yesterday, I could call up that SMA parents and tell them Risdiplam is available, go take it, right?
Yeah.
I think that's a way forward.
Yeah, and a related question. So when, the parents' genomes are being sequenced, so what is the predictive power there that is actually usable in terms of, their potential progeny? Is that something that is, practical, reasonable? Because especially in the West, I think everybody is into, getting their genomes sequenced. So what do you see as any?
See, I have two opinions on this. One is an opinion as a public health person. A public health person would obviously say, I will restrict it to what my government can afford, right? But then you should also believe that a public health system or a public benefit system should force you all to travel on a bus, right? Which we don't, right? We do travel on a taxi or we do travel on an auto because of convenience. Now, who are we as individuals, as scientists, as policymakers, to be able to force an individual to tell that you should only have this? It should be the parents' decision to screen for what they want, right, and know what they want.
Sure. My question was more about, what is the information, the utility of the information.
Is to be able to treat.
Right.
Right. And
so,
what I show is that
what are the numbers
450 odd disorders today are treatable in India. And this has come from clinicians. I didn't say this. This has come from a consensus from clinicians that 460 odd disorders are treatable in India.
I think we had enough question. Any last burning question? One, please.
Yeah, Vinod, absolutely. It's important that we can't ignore genomics as a tool. The key question is, going back to also the neurotic versus psychotic and the benefits, the pros and cons of doing this on a public health scale, is that I think there's a merit in risk stratified populations that you can do screening, where it might become even more important because other countries have done it and the cost of doing things don't seem to outweigh the benefits sometimes, right? So risk stratification, neonatal diseases and antenatal screening, absolutely yes. But for adult non-communicable diseases, there would be merit in actually risk stratified doing things, and it's upon both the industry and academia to work together to define this. Otherwise, what's happening is we are not probably giving a convincing argument either for the government or for the clinicians to say what the benefits are, what the costs are, and what should we do. This is not a question for you, but it's actually something that is work in progress. Unless you define for these sets, this is absolutely essential, and for the others, it is an option. I think otherwise it will never emerge as a consensus.
Yeah, so that's where I said there's a public health opinion versus a personal opinion. A public health opinion, I completely agree to you, because that is entirely dependent upon what the government can afford. And what I can suggest today is that the government is actually saving more money by sequencing a child in an ICU, right? But because just 1 day of extra stay or less stay will recover the cost of the test, right? The government will save money for Wilson's disease because a child can live normally. No, today government covers this. As part of the National Rare Disease Policy, Wilson's disease is covered. Primary immunodeficiency disorders, bone marrow transplant is covered, right? So it's already cost beneficial. Now let's come to adults, right? 1 in 9 in this room would get cancer by the average prevalence of cancer in the country. If you have a BRCA1, BRCA2 carrier, you have 80% chance of getting cancer. Now that would necessarily mean that a risk stratified individual will go for screening, right? Either mammography or biochemical screening to be able to identify it very early on. Just to put numbers, breast cancer in the country, 75% is diagnosed at stage 3, comes with a 5-year survival of 15%. But if you could diagnose them very early, stage 1, stage 2, you have almost 95-99% survival, 5 years. Huge difference, right? Why should we not do that? Given 1 in 150 for breast cancer, BRCA1, BRCA2, just one disease will recover the cost of your whole genomes.